let's talk about kidney stones. So kidney stones can lead to severe complications such as hydronephrosis, pyelonephritis, AKIs, acute kidney injury. Obstructed stone presents with unilateral flank tenderness, colicky pain radiating to groin. Okay, what is colicky pain? Waxing and waning pain. What is waxing and waning pain? Pain that comes and goes. That is waxing and waning colicky pain that radiates to the groin. Hematuria. Treat and prevent by encouraging fluid intake. Lots of fluid. Radiolucent stones. I can't see you. Cysteine and uric acid. Okay, let's talk about each one of them. But before we talk about that, let's one couple of points that generally we need to know. For fluid intake, increase in fluid intake, because the dehydration is a risk factor for all stone formation. Because dehydration leads to supersaturation, which causes stone formation. Okay. What else can we talk about? We can talk about increase in, so I think that's going to go with calcium stones. So let's talk about these calcium stones now. Calcium stones. Calciums are the most common. About 75% of the kidney stones are the calcium stones. Okay. They are either it precipitates with calcium oxalate, hypositraturia, okay, and the calcium phosphate. So calcium can bind to oxalate or the phosphate, leading to formation of the calcium stone. But they have different factors for each one of them. So let's talk about that. Let's talk about the calcium oxalate stones. Calcium oxalate stones are radio opaque. Okay. On CT scan, you will find hyperdense lesion on urine crystals. The crystals will be shaped like envelope or dumbbell. Look in picture A. You have the envelope or dumbbell. So it's like an envelope, right? Look, it's a proper envelope. Look. You know when you open your mail, like you see something like this? Yeah. I mean, there are no gifts here, so. I mean, you might find some gift card. And guess what to wear to Walmart? And I should have got it to some other good place, but no, they're like, buy groceries. I'm like, great, man. Recession is killing me. But anyways, going back to topic, guys. Mailbox, right? Mailbox, envelope. Calcium is like a diamond calcium mail. I don't know how it's dumbbell, but envelope definitely. Sure. For notes, let's talk about this. Calcium stones, most commonly 80% calcium oxalate, more common than the phosphate. Okay, can result from ethynyl glycol antifreeze ingestion. Who would do that? Children. Vitamin C overuse. Who would do that? Old patients. Hypositraturia, usually associated with decrease in urine pH, right? Malabsorption, for example, in Crohn's disease. How do you have something, we talked about this in GI, but to have a clue, in malabsorption in Crohn's disease, what is the most common location for Crohn's disease? Terminal ileum. So when you have the terminal ileum being damaged due to the Crohn's disease, now you can't reabsorb your bile. Bile contains what? Well, the bile contains cholesterol, right? So when you are not able to have the bile reabsorbed, the bile is going to go out. So the cholesterol and with the calcium, they all are going to go out. So oxalate will be left alone. Normally, calcium binds oxalate in the gut and goes out. Now the calcium is binding with the your cholesterol, and it's just with the fats and lipids, and it's just going out. So oxalate is left alone. Oxalate is like, they ditched me, so I'm gonna do something. It goes and gets reabsorbed in the blood, and in the blood it gets filtered by the kidneys. In kidneys it finds its true love, which is its calcium. It binds the calcium. It causes so much pain because they're like, now it's my turn, causing calcium oxalate stones in Crohn's disease with the malabsorption. Okay, now the treatment is either give thiazide diuretic, citrate, or low sodium diet. Okay, now the important points are for this thing. Let's change color and go with some important points. What are the risk factors to have a calcium oxalate? You have, if you have hypercalciuria, that's a risk factor. One thing. Now the other things are hyperoxaluria or increase in oxalate leading to hyperoxaluria. Third thing is hypocitraturia. They mentioned that one. Hypocitrate urea, decrease in citrate. That's why in treatment you're giving the citrate, and that's a good one to know how citrate is going to work. I'm going to talk about that. Then you have the diet. In the diets where you have low calcium intake, if you don't even have calcium, you just got oxalate coming in, and it's still going to get absorbed and lead to all of that, right? Low calcium in diet, or increase in sodium and increase in protein and increase in oxalate in diet. Okay, so these are all the risk factors. But more importantly, what are the two most important risk factors here? One is hypocitraturia, second is hypercalciuria, and third is decrease in calcium intake. So they might ask, okay, can we take calcium? Decrease which type of stones? Calcium stones. But you'll be like, you take calcium and you take calcium and you're relieving calcium oxalate stone. Yeah, when you take calcium binds the oxalate in the gut, takes it out. So there is no formation of calcium oxalate. Calcium oxalate finds a true love. Calcium within the gut. What else he needs? Nothing. He's like, I'm happy. I want to go out. Throw me in water. Not the clean one. Okay. So that's one thing. Now let's talk about how citrate, very important, how citrate as a treatment works. Well, citrate how do you prevent? First of all, let's talk about the prevention, or let's start with thiazides. Then we go to citrate. Thiazides. How do thiazide as treatment works? Well, thiazide increase in renal calcium absorption, or reabsorption, I should say. And when you reabsorb all that calcium from the renal tubules, it prevents the stone formation because now the calcium is not there that oxalate can bind to. So leading to no calcium oxalate formation. Okay. Now to prevent it, the prevention is, first of all, I talked about the calcium, take calcium tablets. That's one prevention. Second thing was to increase citrate intake. And prevention also has to do with you decrease sodium and animal protein and oxalate intake. Decrease sodium, animal proteins, and oxalate intake. But increase intake in calcium. And you were like, how many units do you want to intake? Only moderately increase. not so high, only moderately increase calcium intake and also increase in potassium intake. But most important is this thing. Okay. So that's what you kind of get out of this thing, and I think it's pretty clear. Let's now talk about the phosphate. I lost the note on this citrate, so my bad. Let's talk about the calcium oxalate and the calcium phosphate. Calcium phosphate, same risk factors that I have mentioned before. Same risk factors. Okay. And same preventive methods, because we need the calcium. So this is going to be radiopaque, same as that. Hyperdense. Now the crystals are different. Crystals are only seen in the letter box, right? Like mailbox with the oxalate. Because, when he was away, he used to send the mails to calcium saying hi-bye, right? So now, for the phosphate, it's a wedge-shaped prism. Let's look at. They don't have a picture for it, but wedge-shaped prism. I don't know how to have that, but maybe something like this. A prism, wedge-shaped prism. Okay. Treatment is a low-sodium diet and thiazide. To prevent it, you want to have low sodium in the first place, and thiazide same way. Calcium is gonna go out. Phosphate can bind to it, leading to no calcium phosphate issues, right? Now let's talk about one thing here. It's the increase in calcium. When you increase in calcium, that is when you have the calcium phosphate formation. Okay, so now let's talk about the other ones. That is the ammonium magnesium phosphate, or Strew White. Strew White kidney stones they would precipitate again an increase in pH, not the calcium pH. Okay, I don't know if I was saying calcium, but pH. Again, it's radiopaque, so I'm gonna cross radiopaques. So if something else happens, example, uric, lucent, I'm gonna make it a tick mark. So to differentiate. So this one is only about 15% of population can get Strew White stones. Okay, and in these, what you really have is hyperdense. Same thing, hyperdense. And you have a coffin lid sarcophagus. Coffin lid. Strew White coffin lid sarcophagus accounts for 15% of stone caused by infections. This is very important, guys. So now, how do you increase that pH? It is caused by infection with urease positive bugs, the Proteus mirabilis, the Staphylococcus saprophyticus, the Klebsiella, that hydrolyze the urea to ammonia. When you hydrolyze urea to ammonia, that ammonia increases urine pH. Alkalinization commonly formed the staghorn calculi. So staghorn is the biggest renal stone. So look at picture B, staghorn. It's so big, it's like going into the pelvis, the calyces is all over. The biggest stone, right? How can you remember that? Who causes the biggest stone? Well, look at just the names. 3 big dudes are coming. Guess what? They're not gonna cause small thing. Well, they're gonna cause something big, right? Because they're 3 freaking dudes. Ammonium, magnesium, and then phosphate on top. Dude, you'll be you're dead with the staghorn calculi, right? So That's the way you can memorize that Staghorn cell. They calculate there's two white, three big dudes. Okay, and all they need is a nice alkaline environment. That should be given them by these uricase positive bugs, like the Proteus, the Saprophyticus, and the Klebsiella. So three dudes with the three bugs, or three sort of like they have some weapons with them, which is like Proteus, Saprophyticus, and Klebsiella. Three organisms causing the biggest renal stone called Staghorn calculi. Treatment is eradicate of underlying infection. Eradicate these. I mean, you neutralize them. These are their weapons, so neutralize these weapons. And surgical removal of the stones, right? Surgical. Look, I mean, you got to open up all of the kidney to surgically remove these stones. That alone is very hard. But yeah, that's all what we have for the Stru-White. But what are the risk factors? Now, important things are risk factors. Well, risk factors are recurrent upper UTIs, okay, upper UTIs. Okay, that's a recurrent upper UTI, and then you have the infection with the urease positive bugs, right? What is the pathogenesis here? The pathogenesis is when you hydrolyze the urea that form ammonia. Ammonia is what? Ammonia increases the urine pH, which causes the precipitation of the ammonium magnesium phosphate salts. What is the clinical feature? How they're going to present with? Is going to be obstruction of the collecting system and atrophy of the renal parenchyma. Okay, and okay, so yeah, that's pretty much what we kind of get from the ammonium magnesium phosphate Stru-White. Moving on with the uric acid. Uric acid. Look, uric for uric and radiolucent. Decrease in pH, and now these two are seen with the decrease in pH. Radiolucent, there is minimal visibility. Okay, and they are visible. Okay, then you have the rhombites C or rosettes. Looking at picture C, you can see uric acid. Uric acid. Okay. About 5% of all stone risk factor is decreased. Now they have mentioned the risk factor decrease urine volume. Why would you decrease the urine volume? Dehydration would cause decrease in urine volume. Arid climates, acidic pH, strong association with hyperuricemia, gout. When you have gout, you have a lot of uric acid coming to the kidneys, and if they find low pH, guess what? They're gonna form stones. Often seen in diseases with increase in turnover. For example, leukemia is one of the examples where there's increase in turnover. Treatment is you try to fix this thing, which is decrease in pH, by giving alkalization of the urine, and also decrease the uric acid levels by giving allopurinol. I think that is pretty simple to understand. But let's talk about some pathogenesis here, or pathophysiology. So acidic urine, let's just lie right here. This acidic urine favors the formation of the uric acid, which is insoluble, over urate, which is soluble. And now supersaturation of the urine with the uric acid precipitates the crystal formation. Okay. And the risk factors that they mentioned is the increased uric acid excretion. So now excretion is even one of the other risk factors. Okay, let me just do a risk factor thing here. Risk factor is increase in uric acid excretion is one of the risk factors also. Okay, because that excretion meaning you have so much uric acid in the blood that is excreting so much from the gout. You're getting that from gout or myeloproliferative diseases or leukemias, as I mentioned. Hot, arid climates, which climates, hot, arid climates, and dehydration. So yeah, these are the things that can cause it. Uh, Prevention is also by same thing, alkalinization of the urine. How do you alkalize, or how do you increase the pH of the urine? You can give potassium citrate. Potassium citrate. Okay, that would favor the formation of urate, and that's just going to go out, excretes in urine. So that's all we have for the uric acid. Let's talk about cysteine now. Cysteine, that's also seen with low pH. What other risk factors we have is the presence of a pre-existing crystal nidus or supersaturation of the urine. Most importantly, you're looking at recurrent nephrolithiasis in young patient. Again, very important for cysteine. Maybe they have mentioned that, but I'm just gonna tell you here. When you see a young patient with recurrent nephrolithiasis, you should suspect cysteine. Cysteine being the kidney stone formation, or cystinuria. So let's read. You have faintly radio-opaque, moderately radio-dense, hexagonal, D-hexagonal. Cysteine has hexagon. Look at C. So just close that out. You have hexagon now. Okay. Now, hereditary autosomal recessive condition in which cysteine reabsorbing PCT transporter loses function, causing cystinuria. If it is hereditary, transport defects also results in poor resorption of arginine. When you lose the cysteine reabsorption transporter, you also lose, or you have a poor resorption of arginine, lysine, and arginine, which is the cola. Cola meaning cysteine, arginine, lysine, and arginine, right? Cysteine is poorly soluble. The stones form in urine. So these are all cannot be reabsorbed, and they go straight in. Cola is going in urine. That cola, when going in the urine, but here the cysteine is not even soluble. It is a poorly soluble thing. So what it happens is now, because it is insoluble, it just forms stones in urine. Usually begins in childhood. Of course, if it's hereditary, we begin in childhood, and can form Stanghorn calculi. Although they do put it here, but it's not important to know, because you know that Stanghorn with 3 big dudes, right? Sodium cyanide nitroprusside tests are positive. 16 stones have 6 sides, which is the hexagonal shape. Treatment is low sodium diet, alkalinization of urine, chelating agents like thiopronium, and penicillamine if refractory cases. So here, what we really have is a cystinuria due to hereditary loss of that transport. So when we have loss of that transport, it also loses the other cola, which is the arginine, lysine, and arginine. But the important one is again the cysteine, because it is insoluble. So when it goes into the urine and it just forms stones there, you can give a treatment chelating agents that can chelate that cysteine and take it out. So that's what we have for the cysteine stones. And that's all for kidney stones.